All right, welcome back. Thank you so much for staying with us. You're watching Morning Cafe, and away from politics, let's shift gears now to matters health. Today being a Thursday, we shift our focus to reproductive health, and specifically we focus on childlessness, that is infertility in men. This is a topic that, you know, when we talk about infertility in men, it's often spoken in very, very harsh tones. More often than not, we know that this burden is placed on the woman and not the man. And let's just take a look at a little data. And worldwide, around 17.5% of adults experience infertility, the equivalent of 1 in 6 people, that is according to the WHO. And globally, about 55 million men are estimated to suffer from infertility, of course, with an age standardized prevalence of 1,355 cases, that is per 100,000 as of 2021. That's the latest data, and Dr. will be giving us fresh data if we do have. And in Africa, men contribute to roughly 22% of infertility cases. And locally, right here in Nairobi, a teaching hospital found that 77% of men tested over 5 years had abnormal semen. And joining me for this conversation is Dr. Kireki Omanwe, a fertility specialist at Frontline Medical Services, of course, to tell us what is causing infertility in men. Are we seeing rising cases, and can it be prevented? Is it curable? And, you know, we also hear something about fertility and infertility. Dr. will be here to break it down for us. And kama kawaida, if you have a question for him, we'll be happy to hear from you. There will be a number on your screen shortly. Be sure to call in, of course. We'll be happy to pick your call. Daktari, karibu sana to Morning Cafe.
Asante sana. It's a pleasure for me to be here today.
Great.
Yes.
And to start us off, it's important that, of course, we define infertility,
Absolutely.
you know, for the benefit of our viewer. And in regards to men, you know, more often than not, we just know that, you know, when you talk about infertility, we know it's the inability to conceive and, of course, to give birth. But when you're looking at it from the lens of a man, what does it mean medically?
Thank you. This is a very important topic, and just as you said in your introduction, it affects very many people. So according to WHO, World Health Organization, when we talk about infertility, we talk about 2 types of infertility. The first type is what we call primary infertility. What does that mean? It basically means that there is a couple who is in a relationship, a man and a woman, and they don't talk about what type of relationship, and they have intercourse 2 to 3 times a week, and a space of 1 year, period of 1 year, and they don't have a conception, they don't have a baby. There's a small caveat to that, especially when it comes to the age of the lady. And the caveat is that if the lady is over 35 years, then that period of 1 year is shortened to 6 months. Then there is secondary infertility, where secondary infertility basically means that this couple, they have a baby or they've had a pregnancy in the past, and they're trying to have another pregnancy, and it hasn't happened in 1 year, and they're having regular intercourse 2 to 3 times a week, and the lady is not breastfeeding on a regular basis, because breastfeeding can actually act like contraception. So, and again, the 35 years also comes in. If the lady is more than 35 years and has had a baby in the past, or has been pregnant in the past, then that time period is shortened to 6 months. It is the statistics that you quoted are actually very relevant, because when you look at the developed countries, male infertility affects about anywhere between 2 to 17%. When you come to the developing countries like ours, it is a lot higher. There's a paper which was published by one of our colleagues from Nigeria, and there it was discovered that male infertility affects about 42.4%. So it's a lot higher. In Kenya, because male infertility is not something which is reported, just like, let's say, AIDS, for example, or you know, an infectious disease, so we may not have accurate data per se, unlike other developed countries where they have huge amounts of data practically on everything relating to health. Yes.
And when you talk about secondary infertility, it's quite interesting. And I know somebody may wonder if at all they were able to give birth at a particular point, and now they're trying, but they cannot. Then what is causing that? I know you've mentioned something about breastfeeding.
Yes.
But how long can it go on? And when you talk about secondary infertility, can it be cured as compared to primary infertility?
I'll take a step back, if you don't mind. I'll take a step back and say, first of all, talk generally about infertility in men, the causes of infertility in men. I can start with, without any hierarchy of importance, start with infections, for example. Here we talk about infections, sexually transmitted infections. For example, gonorrhea, syphilis. There was an article, I think it was yesterday or the day before yesterday, about an explosion of syphilis infections in the country. And then we have another bacteria called chlamydia. Chlamydia is a horrible sort of microbe because what it does in women, for example, it causes what we call adhesions. Now, for men, it also causes the same thing. Chlamydia has no symptoms, it has no pain and whatever. So unlike the other bacterial infections. In gonorrhea, of course, you're going to have pain, you're going to have a discharge, and so on and so forth. Chlamydia doesn't. What sexually transmitted infections do, they lead to the blockage of tubes. Now, if I can go a little bit into the anatomy of the male reproductive system, we have the testicles, and then from the testicles, we have tubes which come down, and added onto the tubes, attached onto the tubes is what we call ejaculatory ducts. And these tubes come down and they get into the prostate gland. And from the prostate gland now, there's a tube now which comes out called the urethra. And the urethra, now during intercourse, what happens when a man is having an orgasm? By the way, sperm is produced elsewhere and is stored elsewhere. Only that during intercourse, the sperm moves from where it is stored in microseconds, travels very quickly into through the prostate gland, where it is mixed with what we call seminal fluid, and then it comes out as an ejaculate. Now, the psalmist says we are beautifully and wonderfully made. Some of these things we don't actually appreciate, we don't know about them because we think it is normal. Now, what happens with the infections? Sometimes the infections can block those tubes where the sperms are supposed to pass through. So whatever comes out during an ejaculation is only seminal fluid from the prostate gland, but there are no sperms. Now, is that correctable? Because you're asking some of these causes, can they be correctable or uncorrectable? Like that one, it is difficult to correct that blockage because first of all, the tubes are very tiny. And if you're going to try and open that blockage, you may cause more harm. But there are options of treatment where we can circumvent that process. You may have a problem with infection of the testicles themselves, especially when you have what you call viral mumps infection. When this happens in childhood, it's not a big problem. It is actually even encouraged. But when it happens in maturity, it actually, in a trauma, quote unquote, in a trauma testicles, what happens is that infection affects what you call seminiferous tubules, and then there'll be no production of sperm. Sometimes you have what you call undescended testicles, where the testicles normally, when a boy child is in the mother's womb, the testicles are in the abdomen, and they're supposed to come through an opening such that they get into the scrotum. Sometimes that doesn't happen. It can be on one side or it can be on both sides. This usually is discovered very late in adulthood. When this gentleman is married, in trying to have a baby, it has not happened, and you do a sperm test, there are no sperms. Let's do further test. You do an ultrasound scan, you find there are no testicles in the scrotum. Let's do an MRI, for example, and then you find actually that the testicles are in the abdomen. So undescended testicles. Removal of testicles because of any reason. For example, they can be because of an infection, sperm. It can be because of torsion, the twisting of the testicles. And if there is a twisting, there is no blood supply, so the testicles will actually die, or they can get infected and so on. So my colleagues, urologists, will remove them. So if you remove those testicles, then of course there'll be no sperms at all. And then we have other problems as well. For example, what we call hormonal imbalance.
Yes.
Our bodies are basically governed by hormones. They're the ones which make us wake up. They're the ones which make our bodies grow, and so on and so forth. So if these hormones stop functioning or are not functioning properly, you'll find that there may be no sperm production.
What hormones are we talking about in this case?
Thank you. We are talking here about several hormones. We are talking about a hormone called TSH, that is thyroid stimulating hormone, which is produced by the thyroid gland, which is right in front of a part we call the voice box. A very, very important hormone because it is, I could call it the manager of other hormones in the body. Because if the level is elevated or if it is low, it will affect the way the body behaves generally. We have a hormone called prolactin, PRL. In women, it actually helps in the sense that it helps the woman to produce milk when she's expectant, because the body knows that there is somebody who is growing there, and this person is going to need milk. In men, it is also there, but the levels are very low. But if the levels are elevated, sometimes because of a tumor in a part of the brain called the sella turcica, then it will affect the production of sperm. And then we have a hormone called FSH, follicle stimulating hormone, and another one called luteinizing hormone. Now, these are also hormones which are also found in women, but in men, they help in the production of sperms. And then there is, of course, the ubiquitous testosterone, which is the male hormone, makes us men. The deep voice, the muscles, you know, the aggressiveness, and so on and so forth. So if any of these hormones actually is not where it is supposed to be, it will affect the production of sperm. And that is also a challenge. Then there are other causes whereby you are born like that. For example, you are born without those tubes. Remember the tubes I mentioned?
Yes.
Where the sperm pass through. What we call congenital absence of the vas deferens. So you are born with that and there is nothing you can do. Sometimes you are born with what we call insensitivity of hormones as well, whereby everything looks okay, but the hormones are not working the way they are supposed to, and then you find that you lack even the sense of smell, what we call anosmia. You may also have other issues as well. There are gentlemen who, when in the course of having intercourse, they don't have an ejaculation at all. Or they have what we call retrograde ejaculation. Instead of the sperm coming out, it goes back into the bladder. Then we also have other environmental...
Just hold on there a little bit. When that happens, when, say, ejaculation goes back to the bladder,
yes,
do they notice it as a problem, or is it something that is often overlooked?
You actually won't know. They also won't know.
So they won't know it's a problem? They
won't know it's a problem. So the problem will come when we tell them, okay, fine, we have taken your history, we have talked with your wife seems to be okay, why don't you go and do a sperm test for us? So when you do the sperm test, there is nothing there. And then that is now when you start doing other tests, you find out other possible reasons for this gentleman not having sperm are all okay. The hormone tests are fine. We do a scan, we find the testicles are in the right place. The hormone levels are fine, but how come he's not having, we don't have any sperm? So what we normally do, we tell them, okay, after having an orgasm, go and give us urine. So when we check in the urine, you actually find there's sperms there. Now, there are also other reasons as well of environmental reasons, for example. The foods that we eat, the food production, there are a lot of insecticides, herbicides and pesticides which are being used, and some of these actually get into the food chain, as it were, and they end up on our table. Not to mention diseases. There are also many diseases. For example, high blood pressure, you have diabetes as well. They do contribute to this. Some of the medications that we take can also be contributory to that. Something which is, it's not really anecdotal, but it is also something which gentlemen should also take very seriously, is when we go to the gym, you know, we want to build the muscles and we want to impress our ladies and so on. And then we also take steroids, anabolic steroids. So we take testosterone. Of course, they will tell you, no, we are not taking any, but in some of those products that they take, there could be some testosterone there. And what happens is that when we ingest testosterone, and testosterone is being produced by the body itself, there is what we call a negative feedback. When there is excess of that, of any hormone, the brain switches it off. So it reduces it. So when it switches it off, what happens is that, yes, the muscles will grow, but then down there, things will be completely different. So you find that the testicles will start becoming smaller, and the manhood will also can also be smaller, and so on. So in as much as you are very impressive on this side, on the other side, things may not be very impressive.
Ah, okay. You know, we hear a lot of things online that people who go to the gym sometimes are not good at these things.
Thank you.
But that's beside the point. Where does subfertility now come in, and how do you as doctors now categorize this aspect of, you know, fertility? What do you do to ascertain, you know, that this is subfertility and this is, you know, infertility? And subfertility, if you're talking about sub, does it mean that it's something that, you know, can be controlled, can be treated? There are preventions that can be taken to ensure that, you know, he's able to produce enough sperms to get the lady pregnant?
Now, most of the time, actually, these terms are used interchangeably. Okay. Infertility and subfertility. But if you're to say, sensu stricto, we say infertility, meaning there is inability completely. You cannot produce sperm, for example. You are born with congenital absence of the vas deferens, for example, and so on. That is a completely different ballgame from subfertility. It means that in the subfertility in men, there is an element of the sperms are there, but they may not be what we would like them to be. For example, when we talk about subfertility men, and one of the reasons of actually of infertility or subfertility in men is the quality of the sperm. What do we look for, or what do we look at? When we tell gentlemen, go and give us a sperm sample, and usually this is done by using masturbation, by the way, and men.
Oh, really?
Oh, yes.
Okay. All right.
I can see you're shocked.
Yes, every day is a learning day.
It's a learning day, yeah. Gentlemen find it very difficult sometimes because we advise that they do it in a clinic where a lab is next door. So they give a sample and it straight away goes to the lab. Again, you see some of the labs that most of the time when you go to the clinic, you find the room where you're supposed to give this sample. You know, there'll be movement out here, people walking, you know, and this psychologically can affect the gentleman. You know, gentlemen, we are weak beings, if I can put it that way.
Well, once somebody has admitted that.
We are affected by sound, by other things, especially when you're trying to do something like that.
Low concentration?
I don't know whether you can call it concentration. It's like maybe somebody is listening out there because of that movement, you know, that sort of thing. So quite a number of men are affected by that, and so they may not be able to produce it at that time. We can advise them to produce it at home, but then it must get to the lab within 45 minutes, 1 hour latest, and then the temperature has to be kept, you know, the same. So we advise them that if they are going to produce it at home, then let the lady actually bring it to the clinic. Why? Because we ask them to wrap it nicely and put it between the breasts, because of the temperature. Gentlemen, tutaweka mfukoni, and we'll go whistling down the street. And of course, the temperature, the outside temperature, will going to affect the quality of the sample. So when we get this sample, we analyze it. We want to look at the volume, how much of that is there. And actually, the volume is usually very little, 1.5 milliliters. 2 milliliters. When we get 3 milliliters, that is a lot. And to think that that is where life begins from, you know, it's just it's mind-boggling.
Yeah.
So we look at that volume. We look at what we call pH. pH is what a solution is, whether it is acidic or whether it is basic. And God has created us in such a way that women's vaginas are very acidic. And men's sample is alkaline. So when they meet, the pH is neutral. And that is how sperm can be able to survive in the vagina. So we look at the pH as well. And then apart from that, we look at the number of sperms in 1 milliliter, which is supposed to be 15 million. Not a lot. Then we look at the count, the total count. So for example, if the gentleman gave a volume of 3 milliliters, and in 1 milliliter, let's say there are 100 million, so in the total count will be 300 million sperm, which would be a fantastic sample. Then we look at how the sperms swim. Because in order for them to get to the target, which is an egg which has been released by a lady, they have to swim. Now, there are different types of swimming, what we call motility. There is type 1 or type A, where the swimming, I can equate them to sprinters, 100 meters. So these ones are the ones which swim very fast. And then there is type B, which are the long distance, the Kenyans. So we normally put type 1, type A, and type B together. And we want that motility to be 40% or more. And then type C is usually, they are motile, but they are in one place. They're not making any headway. Type D, they are completely immotile, so those ones we don't count them. Then we look at, out of these 300 million, for example, how many of them are okay? What we call morphology. We only want them to be 4% or more. So if we say, we use the same number of 300 million, 10% would be 30 million. So 1% would be 3 million. So we want only 4%. So out of the 300 million, we just need 12 million to be okay, and we are fine. Now there can be problems with these values. You may find that the volume is low, for example. You may have is 0.5 milliliters. That is very low. You may find that the number of sperms is not adequate, what we call oligospermia, where the number of sperms is lower than what it is supposed to be. So instead of being 40 million, for example, in a count, you find it is 20 million. So that is low.
So at what point can it qualify, to be used during IVF?
During IVF?
Yes.
I'm coming to that.
All right.
I'm coming to that. Now, you may find that the motility, the way they swim, is not there. Instead of being 40%, let's say it's 20%. And then you divide it, that those very fast, type A is, let's say, 5%, and then type B is, let's say, 15%. So it's 20%. We need it to be 40%. And then you may find that the normal forms, the ones which we said they're supposed to be 4%, you may find it is 1%, or sometimes it's not there at all. Now, sometimes you find there is no sperm at all, what we call azoospermia. And sometimes you may find, yes, the sperms are there, but they're all dead, what we call necrospermia. So there can be a combination of these issues. You may find the sperms are low, oligospermia. You may find the motility is not where it's supposed to be, what you call asthenospermia. And then you may find that the morphology, the number of the normal sperms are few. So what we call teratospermia. So we call OATS, oats, not the oats that we eat. So oligoasthenoteratospermia. So we find all this. Now, the beauty of it is that it's not so often that we find gentlemen who have all these issues at a time. Most of the time you have one problem, or you may have two, and sometimes you may have all of them together. Your question is important, and I think gentlemen need to know about it and to hear about it. You asked, at what point do we know now that this sperm qualifies for an IVF or not? Even fast before we even go to IVF, this couple has come to us. They've been trying to have a baby for a year, it hasn't happened. But then sometimes, most of the time, you find they keep on trying. I saw another couple the other day who told me, tutaendelea kuomba tu, and the man has azoospermia, meaning he's not producing sperm at all. So in my mind, I'm asking, okay, it is good to have faith, but again, as the Bible says, faith without works is not
dead.
what is dead. So, of course, you don't try to convince them. You say, you know what, okay, praying is good, but we know where the problem is, and it can be solved in one way or another. But let's use them complementary, not only prayer. Because he'd been married for 8 years with one wife, and the wife left him. As soon as she left him, she went and got married, and hey presto, she had a baby. Got married again to another wife, I think for 3-4 years, nothing. Went and got, the wife left him, went and got married, and she has children. So now he's on wife number 3. They've been married for 2 years, and still there is nothing. And you see, now this is about 10-11 years, and they've never actually gone to look for assistance. So when he came, we did all the tests, and of course the semen analysis, the sperm test, there was no sperm. And we did a scan, what you call a scrotal scan. The testicles are okay, hormone levels are okay. So basically what the problem is a blockage of those tubes. Now, once we have realized that, yes, for example, in this case, there is that blockage, or, for example, the numbers are not there, or the motility is not there, or the normal forms are not there, what we want to do, number one, is to try and help, to try and support the body to produce a better quality sperm by giving them medication, supplements, and usually they take them for 2.5 to 3 months because the cycle of production of sperm is takes 2.5 to 3 months. And again, this is where life can be a bit unfair because ladies, unfortunately, mnazaliwa with the number of eggs you're going to use the whole of your life. So with the ladies, the number of eggs keep on falling every month that you have a period. So that is why we advise ladies after 35 years, if you are really intending to have a baby, have them before that time, because after 35 you're going to struggle because the number of eggs has reduced. The quality as well, unfortunately, also does reduce. It is opposite for men. Men, tunatengenezaga tu. Every 2.5 to 3 months.
Age doesn't matter.
It'll matter later on, but it will matter in a slightly different way. That is why you may find a mzee who is 70, for example, just choose a number. If you can be able to stand at attention, na apate kasichana vizuri, anatampatia mimba. That is why we have all these what we call bad cultural practices, where you find very young girls getting married to older men and so on, but they still get pregnant. Now, age will affect the man later on, in the 45, the 50s, because of just the natural aging process. It will affect the DNA in the sperm, but not the production of sperm. Now, once we have had a discussion with this couple, we've gone through, the history, medical history, surgical history, because, by the way, surgery can also be one of the causes of infertility, especially when we have what we call hernias, what we call inguinal hernias, and there the vessels and other tissues can actually come together, and if it is not done well, you may end up actually chopping those tubes that I told you about, vas deferens. Now, we know that there are no problems at all, or if there is a problem, you may have a swelling of the veins in the scrotum, what we call varicocele, and it is one of the biggest, the most common issue when it comes to male infertility, which is reversible. And then the varicoceles, again, it depends on the type of grade. There are four grades of varicocele. Sometimes you may have fluid also around the testicle as well. Now, we have looked at we've listened to the history, taken the medical, surgical history. You're not taking any drugs. Smoking is a problem. It's a big, big challenge, because in the cigarette smoke, we have about 2,000 to 3,000 chemicals. Some of them are heavy metals, chromium, for example, which goes during the production of sperm. It goes and displaces zinc. And zinc is very important. Why? Because this is actually what makes the sperm swim. So if that zinc is replaced by chromium, which is a heavy metal, those sperms are not going to swim. That is why we ask, unavuta sigara, ngapi, ati kumi. How long? 10 years. Please stop. Apart from it giving you bad breath is also affecting, bedroom issues as well. Pombe is also another issue. When gentlemen drink, and Kenyans love their drink, what happens is that you become inebriated. With inebriation, bedroom activities probably zero, or you end up in very funny situations. You don't know whom you slept with. The morning you wake up, you find, Allah, how did I end up here? And you don't know, the health of this other person. So we've gone through all that. And then we have sent this couple for tests. The lady, we have done tests. We have looked at the hormone profile. We've checked those 3 hormones that I mentioned, prolactin, thyroid stimulating hormone. We've looked at a hormone which tells us about her ovarian reserve. And we find that everything is okay, for example. Yeah. And then we have checked her tubes as well. And we find that the tubes are okay. We've checked her ovaries, and we find the ovaries are fine. The womb is fine. So the gentleman, usually gentlemen want to have their test last. Sema enda kwa daktari kwanza, alafu nilete report.
Why? Why is that the case?
I think this is my own assessment. I think it is the way we have been socialized. That men do not have an issue. Men don't have a challenge. Because even in the Bible, they always say Sarah was barren. Rebecca had a challenge. Rachel had a challenge. Right. You don't hear men saying a man had an issue. Yeah. It's always sort of, it's women who have this challenge. And I think it is the same carryover, because even now, when a couple is married and they don't have a baby, it's like, what's wrong with this woman? Yeah. There's something wrong with the woman. And the problem can actually be with the man as well. So once we've finished with the lady, we normally would like to have to assess them together. But if they can't come together, that is fine. Let the lady come first, and then the man can come later on. Very, very rarely will the man come alone. Like Nicodemus went to Jesus at night. Wanakuja mara moja ni kama wanajificha. He said, daktari, I've been trying and something is not okay. I just decided, I haven't told anybody, what could we do? And those are really heroic men, because they realize there is a problem and they're coming to look for help. Most men don't look for help because, again, as I said, we are socialized that way. We are macho. We are not supposed to be weak. We don't have any problems, but we have a lot of problems.
And that brings me to this other question. It ties to whatever you're talking about.
Yes.
The NSDCC, that is the National Syndemic Diseases Control Council, last year they released a report and say that, the health-seeking behavior of men is quite terrible. And if you're talking about men coming in to check for their, fertility, is it improving, or, there's still sort of a gap in terms of how they're just coming to check how their fertility is? There is
a huge gap. There's a huge gap. And one time I attended a conference, I can't remember where it was, in Barcelona, somewhere in Europe. And there was a professor from Denmark who presented a paper. And in that paper, she said she was, again, the same health-seeking behavior. And what they just wanted to find out, an anonymous questionnaire, and the gentleman would call a radio station and say, look, I'm having a challenge and I've been tested, I'm this and this, and anonymous. Don't say your name, don't say where you're coming from, don't say where you are, just a name. No one called. No one. Unajua, I felt a bit happy because I said, we have challenges in Kenya, and the challenges are similar. We thought that out there, because of stigma, development, whatever it is, they're so-called civilized, so some of these things will not be a challenge. But you find that it's actually across board. So men, as I said, the way we are brought up, when you're a child, you're playing football, you fall down, you graze your knee, you start crying, you run to your mom says, Allah, kwa nini unalia? Wewe ni mwanaume. Mwanaume hawali. And then, so we suppress those emotions, as it were. That is my assessment. So when it comes to serious issues now, and very personal and very sensitive issues, you don't want to talk to them about anybody. You want to keep them to yourself. In any case, you are a man, you are strong, and whatever, you are macho. Unlike women Women, you go, you have a charmer, you have your friend, your buddy, you'll call, I say, hey, I'm feeling stressed. Situkutane tu kunywe chai. And when you sit down, you talk about anything, your boss, you talk about your useless husbands who don't listen to you, you talk about your heavy periods, whatever. After that, you know, everybody's, you're feeling whatever better.
Absolutely.
And you go home, and men don't do that. Men will talk about how Chelsea beat PSG the other day, and you see how what is happening in Ukraine, you know, and so on and so forth. But personal issues, we don't. And again, it also happens that, you know, you can be a group of gentlemen, your friends, you start talking, you say, you know, guys, me, I'm having a challenge. I'm having erectile dysfunction. Guys, watakwambia ala, kwani boss ni nini? Situkusaidie, you know, that sort of thing. It can be spoken in jest, but then the effect will be horrible. Because you opened up, you are vulnerable to, you know, to your friends, and then they didn't take you seriously. Unlike women, you are vulnerable to each other. You can open up completely, and the other person will not judge you. Utaongea tu, say it will be well, and you'll go home. So health-seeking behavior amongst men is horrible. We, I think men generally, we'd rather take care of our cars and other things, because your car, you'll take it to the you know, for a washing, you know, every weekend, for example. You'll go for a haircut, you know, whatever it is. Lakini hiyo kwenda kwa daktari, atienda upimwe damu, ati sijui toa sampuli hapa tuangalie. And worse still, go and have your prostate checked. Boss.
And the WHO, of course, says this is a global existential crisis.
Yes.
But should we be concerned about male infertility in Kenya? If you're talking about the developing countries, we're also seeing a rise as compared to developed countries. But what are we not doing right, you know, to just have this spike in regards to male infertility?
I think there are many things which we are not doing right, right from the beginning, right from when the boy child is born. I mentioned undescended testicles as one of the problems. The mothers who take care of these boys, when they're washing these babies, they should just feel gently, you know, the testicles, because they can feel there's something like a small bean inside the scrotum. If it is not there, they should take this baby to a specialist as soon as possible, because it has been noted that correction, because the correction can be done even as early as 1 year old, then later on the effects are not there. But if it is left because you also didn't know, and the child grows and becomes a man, you know, and the testicles are undescended, obviously you're going to have challenges with that. We need to talk, we need to be very frank about our sexual behaviors. When a man has, you know, several affairs, and the so-called body count is large, they are called macho. But you know, with that quote-unquote body count, you don't know what you're getting yourself into. So sexually transmitted infections are on the rise, and there is data to that. Our social behavior, what we eat, what we drink, the smoking bit, you know, it may be the cigarette itself, maybe vaping as well, but they have the same effect. Not to talk even about cannabis, which is very common amongst college students, university students. You know, you feel high and you feel on top of the world, and so on and so forth. Apart from it inducing, you know, some psychosis, cannabis-induced psychosis, it also affects, you know, the production of sperm and so on. What we drink and what we eat. Again, obesity can also be a challenge because when a gentleman is obese, what happens is that in what we call the peripheral tissues in the fat, the testosterone is converted into estrogen. So the male hormone is changed into estrogen, and that will affect, we start having a man having man boobs, as they call them, and the production of sperm goes down because estrogen affects them, production of sperm as well. Exercise, we're not doing as much exercise. So in that exercise, what is released is what we call endorphins, and the endorphins are the good feel hormones. And with that, you feel better. Even when you go to the bedroom, things will be better. If you're going to do the lifting and muscle and whatever it is, then let us try and do it organically instead of using other additives, which may have issues, you know, down the road. And then, of course, the issue of advocacy. If you have a challenge, these challenges can actually be overcome. So men need to know that even if there is an issue, don't keep it to yourself. Tuko hapa kuwasaidia. Yes.
All right. And is it possible for, you know, the sperm count to hit a plateau and for the man to just be relatively fertile? Or, you know, once we say that the sperm count is low, there's no possibility at all of being able to get a woman pregnant?
Things happen in this world which sometimes, you know, medicine doesn't read books. You will read books, and these are the standards, these are the observations, and this is the science, this is the research. And then you find somebody has got pregnant just like that. You find, you know, we thought the sperm test was not very good. The numbers were not there, or whatever it is. And then he comes and says, you know, they come and they say, you know, we are expectant. I don't want to suggest other things that maybe could be because of, you know, somebody else has helped you. It does happen, by the way, and it does happen very, very frequently. But we are assuming that this is a legitimate, you know, honest couple in a relationship. Now, ideally, the more normal the sperm is, the higher the chances of pregnancy. So you are asking whether this sperm can hit a plateau somewhere, and then things happen. You see, if you had to do a sperm test today, for example, and then you do another one after 3 to 5 days, there can be a small variance. It won't be exactly the same. But even the variance won't be, you know, today is, let's say 100 million, and then after 3-5 days, it is 20 million. Then something is wrong, either with the lab or with the system in itself. So yes, sometimes that can happen. But having said that, when we see that there is a problem, we help with this problem. We help to mitigate this problem by giving these patients supplements and so on. And if that doesn't change, because sometimes it may not change, let's say, for example, the patient has a genetic problem, so we cannot change a genetic problem. And usually they say when you see, you give a patient supplementation, you give the patient medications and whatever it is, and still the numbers don't change so much. Sometimes actually the numbers even become worse with time. Then most probably there could be a genetic issue. And that is where the IVF comes in, the treatment. We have finished with the diagnosis, we know where the problem is. And by the way, for IVF we can do it because of female factor, or the male factor, or even both of them. So in this case, we are focusing on the male. We have given them supplements, we've treated them, and it hasn't worked very well. We want to capitalize on the sperm that we have, because IVF is generic. When you say IVF is in vitro fertilization, where instead of a baby being formed in the tube and then implanting in the womb, the baby is formed outside, is created outside. So we stimulate, we give the lady medications, because generally a woman produces 1 egg in a month in a cycle. But in IVF, we give this lady injections, medication, every day for about 10 to 12, sometimes 14 days, so that she can produce as many eggs as possible. Once we have ascertained that she is ready, we take her to theater and we remove the eggs through the vagina. We don't cut anywhere. So once we've got the eggs, the gentleman gives us a sample. Hata kama ni ile 50-50, we will try, we clean that sample, and then we choose the best sperms that are available. Because unfortunately, in men, there is a lot of loss. Because even out of those 300 million sperm, you only need 1 sperm to fertilize 1 egg. So once we've cleaned that sample and we've chosen the best sperm, there is a scientist who works in a lab called an embryologist. He or she will take that 1 sperm and inject it into the egg. Let's say we have 10 eggs. So we inject all of them and then put them in a warm environment. They will start growing and dividing. Usually it starts by 2 cells, then it goes to 4 cells, and then on day 3 it goes to 6 or 8 cells or 10 cells, and so on. What we talk mbali sana, by the way, from 2 cells. And then once they are ready, we do a transfer we take these embryos now, this is the beginning of a baby, and then we do a transfer into the woman's womb, uterus for that matter, and then we give them medication, we give the lady medications, and after 2 weeks she comes to check, do a blood test to see whether implantation has occurred and the baby has stuck. Now, in cases of, for example, where the gentleman has no sperm at all, what we call azoospermia, we can do what is called surgical sperm retrieval. We've checked the hormones and the hormones are fine, meaning that the sperm is being produced, it is only that it's not coming out. So we do the same thing, we stimulate the lady, we get the eggs out, then we take the gentleman also to theater, put him to sleep, and then we retrieve, we get sperms from the testicles, and then we do the same thing, what is called ICSI, alafu tunafanya transfer pia.
All right, quite an interesting, insight there,
Yes.
Daktari. And of course, we've come to the end of this conversation, but for somebody, if they want to come and follow up, they want to come and consult Daktari, where can they find you?
I'm located at 5th Avenue offices, and this is along Ngong Road, and my office is called Frontline Medical Consultants, and it's located on the 3rd floor. So Frontline Medical Consultants, 5th Avenue offices, Ngong Road, 3rd floor, 314. I'm there and I'm available to help the gentlemen, not only the gentlemen, but also the ladies as well.
All right, interesting. And thank you so much for talking about, the causes, the symptoms, and of course, treatment that are available for men who are, presenting as infertile. Thank you so much. That brings us to the end of this conversation. That is Dr. Kireki Omanwa, fertility specialist, once again at Frontline Medical Services. To stand by for, you're still watching Morning Cafe. Good morning. My name is Anne Odida. Up next, State of the Nation.